Okay, now we're going to look at the ADP receptors. Um, and so there's two types. There's P2Y12 and P2Y1. These are G protein coupled receptors that are specific for the ligand ADP. If you block either of these receptors, you severely restrict platelet activity, platelet activation. Um, in terms of the mechanism, if you look at the P2Y12 receptor, that couples to a GI subunit, and when stimulated upon inhibits adenyl cyclase, the outcome here is going to be a low reduction, or I'm sorry, lower level of cyclic AMP, and then less cyclic AMP means kind of a less cyclic AMP dependent inhibition of platelet activation. And so these drugs are really potent platelet inhibitors by inhibiting the activation cascade. Clopidogrel and ticlopidine are both irreversible inhibitors of these receptors. Nice schema is shown here. Clopidogrel seems to be a little bit more potent and has kind of a better toxicity profile than ticlopidine. The other thing too is that there's been genetic polymorphisms that have been kind of discovered for ticlopidine, and so you see ticlopidine kind of falling out of favor. And it's been evidenced, it's been shown that there's been groups of patients that have phenomenal responses to this drug, followed by groups of patients that have relatively poor responses, and that's due to those genetic polymorphisms. So over time, ticlopidine, even though it's extremely cheap, has been gradually kind of replaced by clopidogrel. And in terms of adverse effects, you can see nausea, vomiting, diarrhea. The most severe would be neutropenia. Prasugrel is kind of the new kid on the block in terms of the drugs in this category. And what's really nice about Prasugrel is that the onset of activity is a little bit more rapid than either of the previous aforementioned drugs. We see a really greater, more profound, and the key, more predictable inhibition of platelet aggregation. And it's a much better alternative than ticlopidine for sure, because we've seen these polymorphisms in these P2Y12 receptors. So clopidogrel works relatively well. Prasugrel is a little bit better. It was also brand name, and I think the patent is going to be expiring sooner than later. So you can see a lot of patients on clopidogrel and prasugrel used in the clinic right now. Other drugs that kind of don't really have a class, but I wanted to briefly mention them. These are parenteral anticoagulants. Drotrigocin alpha is really just a recombinant form of that protein C, which is kind of the endogenous kind of in-house anticoagulant. And of course, there's a recombinant form of antithrombin that can be supplied, and it's produced from the milk of genetically modified goats. This particular drug would be really beneficial for patients that have a hereditary antithrombin deficiency who need to undergo surgical procedures. And so remember, heparin wouldn't necessarily work for those patients because they don't have antithrombin. So you'd have to co-administer heparin plus antithrombin to really anticoagulate them appropriately. So this was the last group of drugs for the anticoagulation lecture series. Again, if you have any questions, please email me or call my office. Thank you.